Welcome. Awesome. Looks like we've got a good group of people who showed up here, many of you early. I am thrilled today to have Dr. Eddie Mockus joining us today, all the way from Colorado. Eddie earned his doctoral degree in school psychology from Illinois State University, and then subsequently spent 3.5 years completing training as internship and postdoctoral training in the Child and Family Therapy Clinic at Kennedy Krieger Institute, Johns Hopkins School of Medicine. Ever since then, he moved out to Colorado and he opened up a practice out there. He works at the Boulder Center for Family. He works and owns and founds the Boulder Center for Family and Behavioral Health, where he does outpatient psychotherapy for children, teens, families, and young adults. He also serves as an adjunct clinical professor for the Child Clinical Psychology PhD program at the University of Denver, where he teaches cognitive behaviorally oriented family systems therapy. So I'm really excited to have him with us today, presenting to us on a topic that I know many people have asked us time and time again to talk about. How do we work with difficult families? What are some strategies to be effective? Because I know many of us have worked with families that have been challenging in the past. So Dr. Mockus, take it away.
Thanks, Caleb, for the intro. I hope to live up to what sounds like a high standard there. So great. Thank you, everyone, for joining. As we go through this, there'll be certainly sufficient time, I think, for a question and answer and an actual application. I'm perfectly comfortable with you sending questions through the chat, and I think Caleb, Dr. Corman will kind of read those off to me just so I don't have to keep an eye on that. But I'm also very comfortable with just a quick unmute and ask the question kind of in the moment. We'll stop for a couple quick questions throughout, but I'm certainly hoping to have sufficient time at the end. So everyone's questions or actual application questions feels answered. So this feels like a good use of our time. Okay. So I am going to talk to us today about strategies for working with difficult families. Let's dive in. As far as a general overview goes, there are three main concepts I'm hoping to discuss. One, I want to talk about, well, just conceptually, what makes a difficult family and what makes a client difficult in the first place. Two, I want to talk a lot about treatment resistance and maybe a theory around where it comes from and why it's maintained, specifically within the stages of change research. And third, I want to talk about functional family therapy and a brief overview of how functional family therapists tend to conceptualize cases so that as we move forward, we all can attempt to take an FFT mindset to the cases that we work with. And we'll have some time at the end for Q&A. All right. So this is a very conceptual start to this presentation because it's common knowledge as therapists. This is what we say to our supervisors and our supervisees and our colleagues, when we're in consultation, right? When a client or a family or a patient or a parent, right, isn't automatically open to our treatment, doesn't immediately utilize our clinical advice, right? This is the language we use. Like, this is a difficult client. They're hard to work with. Conceptually, I want to challenge all of our thinking that the language we use around difficult clients directly impacts our approach to care. In some cases, I might actually argue that the language we use around difficult clients and how we label difficult clients actually builds up our own treatment resistance towards those clients and towards those families. So in a way, the first step or the first skill or the first strategy in working with a difficult client is to actually shape our language around how we conceptualize our client's difficult behavior. That way, we're better able to see our clients in context to their life history, to their life situation, to their past clinical behavior. And when we can do that, we can have a much better conceptualization of what to do in the room when it's actually time to provide that service and that treatment. Okay. The difficult client is a learned behavior. right? These people aren't born difficult, right? They're made difficult through their past experiences. No one actually chooses to be a difficult client or a difficult case or a difficult family. Our ability to use, gosh, the first 3 sessions even to just take history of symptom severity and complexity, right? Kids that have higher symptom severity, higher trauma complexity, higher family complexity with history of mental health issues or trauma or whatever it may be, right? That's harder to treat. That's harder to find, to meet our treatment objectives, right? And when we learn that we're hard to treat or treatment doesn't work, we're less likely to be open in therapy. When we're less likely to be open in therapy, we're more likely to be closed. When we're more likely to be closed, we're more likely to appear resistant or difficult when we're just not hopeful. What is our patients' logistical or cultural access to care? Shoot, what is their access to good or right care or appropriate care even? If we could take a step back from a difficult client and say, okay, wait a second, logistically, is this their first time coming to therapy, even though they're, X, Y, and Z, years old or X, Y, and Z years young? Can I even make it to therapy? Do they have to take several buses to get to therapy? Culturally, is there still a stigma in this person's, subculture around accessing therapy? Do we view therapy as something that's positive and desirable and a good thing for like regular life maintenance? Or do we see therapy as a punishment or a failure of sorts? Right? Our ability to understand that access to care and that logistics helps us conceptualize where their resistance is coming from. If we could do that, maybe they seem slightly less difficult to work with, and maybe they seem slightly more understandable where that treatment resistance is coming from. Let alone access to good care. I'm not sure as providers, the exact, if you're the first line of treatment for a lot of the cases that you work, but I'm rarely the first line of treatment in the cases that I work. Sometimes I'm the 3rd, 4th, 5th provider that some of my families see. And usually by that point, most kids, most parents, most families kind of had it made up in their mind, how they feel about therapy and whether or not it's effective. Okay. I know a big conceptual start today, but our treatment conceptualization and our treatment philosophy around languaging what makes a difficult client is first and foremost our best approach and our first strategy to working with difficult folks. I will argue that perhaps, despite me using this language myself, perhaps there's no actual such thing as a difficult client, but rather clients or families or parents or kids that just need more support. They need more validation, and they just need more proper treatment consistency to meet them where they're at and where they've been, rather than just trying to push them forward. Okay, in a big way, this conceptualization and the mindset we take into the treatment room, that's in a big way the main foundation and underpinning to the further slides as we move forward. Fun, here we go. All right, let's talk about treatment resistance, specifically within a changes of stage format. Usually when we talk about difficult clients, we're talking ultimately about treatment resistance, because this is how it presents behaviorally. So if we're trying to manage treatment resistance, it's ultimately best to understand the concepts that model treatment resistance. I think this is best found in the stages of change literature, which originated from historically, right, hard to treat addiction populations. I imagine many of you are aware of the stages of change, but if you're not, there's generally speaking 5. You've got your pre-contemplation, contemplation stage. You've got your planning, action, and relapse stages. So pre-contemplation, this is the stage where when you're working with someone, they don't seem to think there's even a problem to address, right? They're in pre-contemplation. Maybe they recognize there's a problem, societally speaking, but it doesn't apply to me specifically. That's when they're in contemplation stage. Maybe they're saying, well, what can I do about this problem that does apply to me? We're in a planning stage. And once we put that plan into place, that makes us in the action stage. But once we realize, this action isn't working, this action is too difficult, this plan is not sustainable, that's when we tend to relapse and move back to pre-contemplation. Per theories of stages of change, there are two main sources of treatment resistance. Treatment resistance comes as a function of a mismatch stage of change. I'll explain this further, as well as a function of burnout, essentially being stuck in the relapse stage. Okay, when, I don't know about you, but me as a therapist, when I enter the treatment room, I almost by default enter the treatment room in the planning and the action stage, right? I'm ready to go, I'm ready to listen, I'm ready to hear what's going on, let's set up our goals, and then boom, I've got a whole bunch of skills in my brain that I can give to you, and we can just action this out, right? We start in the planning and action stage. But how often do your patients, your families, your kids, your parents all start in that planning and action stage? Half of them, 80% of them, 20% of them? I think it's probably closer to 30 in my experience. Because some of them, they don't know how therapy works. Some of them, they don't know that therapy can work. Some of them are contemplating, is therapy even for me? Are you the right provider for me? This is all contemplation-based language that we're not even ready to plan. So I might argue, if we don't come into treatment with this knowledge of what stage are my people in, we excited therapists, good therapists, might actually accidentally build treatment resistance in being too eager to jump into the planning and action stage. If we're in planning and action, they're in pre-contemplation, resistance. If a parent is in action mode, but the kid's in contemplation mode, resistance. If the kid's ready to go, but the parent doesn't realize they need to be ready to go, resistance. The key here is to take a step back, and when you notice treatment resistance, you say, might it be because I'm pushing for planning and action and they're somewhere else? Might it be because I'm just contemplating and contemplating and contemplating and they're ready for action? Right? If we can be aware of this mismatch, we can take a step back, stop what we think we need to be doing, and provide skills specifically related to that stage of change. Let's dive in a little bit further. Okay. From a practical perspective, if you're in session and you're asking yourself, oh my gosh, why is there so much resistance here? And you recognize, oh, that's because there's a mismatch stage of change. Here are some things you can consider. Step one, as a therapist, just don't rush diving into planning and action. If we take that first slide we talked about, we can start out thinking like, what's this patient's treatment history? What's this family's treatment history? Right? Does this person even want to be working with me? Right? Don't rule out staying in pre-contemplation, even contemplation for a while, even though to us therapists that might have a limited amount of time to work with certain clients and certain families. The most effective treatment we can give to a hard to treat family is staying in contemplation if that's where they're at, because that will ultimately feel like a better match therapy for them. Even if we don't actually get to the skills, even if we don't actually get to, that outcome data that we try to take to measure our treatment progress, our ability to just match to them is going to be ultimately more effective than trying to push a protocol onto a client who's not ready to receive it. And now they hate therapy even more. So help yourself by not rushing into planning and action. Educate the other people in the room about the importance of matching stages and highlighting when people are mismatched. right? When you got a kid who's frustrated because mom or dad's not showing up, let them know, be like, hey buddy, here's, I think, the stage that they're in. So we got to cut them some slack so we can kind of get you guys joined up. Same thing with the parent. Parents like, kid's just doing this, that, and the other thing, right? He's not ready. He's not ready. Resistance, resistance, resistance. Well, that's probably because, he doesn't know yet, right? How important it is, the things that we want him to do. He doesn't see how, I don't know, whatever the treatment specific is. Homework comes to mind, right? And like future, like why does this class matter kind of thing, but that's a surface level issue. When we educate all the people involved around the stages of change, so we can match to the stages of change, we can put the treatment resistance on the table in a transparent way that we can then talk about it and figure out what moves we need to make, what barriers to treatment we need to uncover, so that we can then align into the planning and action stage where we prefer to be. If you're using traditional stage of change research, most often we talk about readiness to change here. Contemplation stage does not only target whether change is needed, but who is responsible for that change. Sometimes when we're doing family work, sometimes parents just don't know their level of responsibility. They don't know how powerful their presence in session can be and how powerful their presence as a model can be for their kids. And so sometimes just simple education can go a long way there. In the end, the best specific skill you can use is the use of contemplation language, regardless of whether they're in the contemplation stage, but throughout therapy. Now, this is best modeled in like the motivational interviewing research, or practice. These questions around, how's that working for you? Like, what do you notice? Like, what happens when you do that? Talk me through it. Hey, teach me where your hesitation comes from. Because every time I bring this up, you kind of shut me down. Teach me where that hesitation comes from. Right? Hey, earlier you said you wanted to build trust from your parents, or build trust from me, yet I see you doing this. Walk me through that. Tell me about your decision-making there. The more we can get the patient or the client or the family to just keep talking about and contemplating, right, their point of view, eventually they'll identify the discrepancy in what they're doing, what they want. And once they recognize that mismatch, it's natural for humans to want to plan around, building that congruency. Right? So then we're in the planning stage. Oh, cool. Let me help you with that. Oh, cool. What can you do differently? Now we're in planning. But if we rush, here's what you need to do differently before they're ready, resistance. Because we're in planning and action, they're just still contemplating. Pay attention to your own resistance. I know when I'm raring to go and I, sometimes get a patient that just yes buts me, right? Like, oh, did you try this? Oh, I have, but, or did you consider this? Oh yeah, I have, but. Like, I notice my own resistance to be like, oh, come on, buddy. Because I want to push them along the stages sooner than maybe they're ready. So when in doubt, instead of continuing this cycle, process that out with your clients, process that out with your family. Say like, hey, am I too eager here? Or am I missing something here? Am I too naive here? Like, what am I missing? Because, I feel like I'm tossing out some pretty good recs, but for some reason they're not hitting. Talk me through that. Why aren't you ready? What's stopping us? Why doesn't this feel like a good fit? If they can contemplate us through that, now I stopped being this kind of authoritative teacher figure. And now I'm someone who is truly trying to demonstrate, let me understand where this resistance comes from, rather than accidentally creating more resistance myself. And the second that patient actually tells you, well, here's where the resistance comes from, or here's why, your recommendation is stupid, Dr. Eddie, then I'll say, okay, great. I'll validate the heck out of their perspective and their response. because I want them to know that I actually hear them and I can actually be different than any other provider, any other patient, or any other parent, any other mentor that you've had. Like, I'm actually here to listen and try to figure this out. And giving yourself permission to stay in contemplation is a great place to do that. One more slide. I'm going to pause for questions if you have any. But slightly different than just a mismatch in stages of change. Sometimes treatment resistance simply comes just from burnout. Using stage of change language when a client or parent just gets stuck in the relapse stage. So burnout's a slightly separate category, right? And it's very quite possible that your patient doesn't actually need more skills. They just need more hope that the skills they already have are actually going to be useful, right? Or they just need more hope that you as a provider is going to be a different type of provider than maybe they've seen before if they've had a bad history, with providers in the past. And in some not quite extreme cases, but in some cases, we can actually validate that being stuck in relapse can actually be a protective factor for a lot of patients and a lot of families and a lot of clients, right? Because it hurts when you try something new and it doesn't work. And then you try something again and it doesn't work. And you try something again and it fails again, right? At some point, it's a protective factor to stop trying. So as a therapist who's almost always in planning and action stage, if we give ourselves permission to say, hey, talk me through your burnout. Hey, talk me through, in our first CBT session, right? Instead of like tossing the triangle at the kid, be like, hey man, tell me about your past therapists. Tell me about how therapy's gone for you. Tell me about what's worked. Tell me about what's just been awful in therapy so I don't make those same mistakes. When you have a patient or a client who is not responding to those typical CBT triangles, there is likely a barrier there. If you just take that step back and say, hey, talk me through it. Talk me through your burnout. Talk me through why you've learned that this doesn't help so I can better understand you. Now you're actually talking about stuff that matters rather than trying to convince them to do a behavior that they're not ready to do. So when we recognize this is the factor, don't discount validation. Just have validation after validation after validation after validation session. And this comes from a behavior therapist who prefers to give, applicable skills every single session. But in this case, don't. If they're stuck in relapse and you keep giving them action-oriented items, you as a provider are just going to accidentally increase the resistance in the room. So stop doing that and match to their stage of change. Increase their access to support, because if you're burnt out, you need more support that actually feels supportive, right? Don't just throw the book at them, try to contemplate with them to see what support would actually feel good. Increase their access to hope for the change, hope for the future. They need to know that therapy can actually be helpful. They need to know that change is actually possible. They need to know that the future can actually be brighter eventually. And actively recognize with them, I get it. Burnout can be a protective factor in the short term, even if it's not long-term effective. Talk that out with your person when you notice this is the pattern that's happening. Put your treatment protocol aside and just be real with where are we at with these stages? How can I better match with you? Let's go from there. Okay. I'm going to do a mini pause. Just see what reactions you're having, what questions you're having, and what comments you're having about what we're covering so far. Solid.
I realize that one of the things that I'm feeling right now in a community mental health setting is a frustration, that the caseloads are so high that we are being told that lingering, if we're not making active progress, basically matching to their stage of change, they're saying if they're not there, we need to discharge and be able to focus on people who are in the planning and action stage of change.
Good, Amy. Yeah.
And again, insurance, Kentara is telling us the same thing. And I want to match, but there is so much outside pressure that we can't just maintain until they get to that stage. So
yeah,
and that's I know this the truth of all this, but trying to fit it into the context that I'm in is really difficult.
Yeah, Amy, you're absolutely right in every single way. Right. This is often why, having, APA-based lobbies and, pushing for that type of legislature that allows for whether it be the funding or more providers or, insurance companies that get it, right, and stop limiting like only 10 sessions and you're done kind of a thing, which is really, really difficult. My typical response to that concern, and I share those same exact concerns, my typical response to that and to whether it be insurance companies, if I'm, writing letters of support, for, single case agreements or things of that nature, which I know is a big time consuming factor, is if we push for an action stage, before a patient is actually ready, we're not actually going to get them into doing action, right? So we think we're doing it because that's what the insurance companies or the treatment and even like the traditional treatment protocols, right? Like if I'm running a coping cap for anxiety, it doesn't necessarily give 3 to 5 sessions of just matching with my patient, right? It says like, hey, here, welcome to the coping cap, and here we go, right? And so or whatever treatment protocols you guys use, if any specific like that. And so the problem is, and I'll get into this a little bit more when we talk about FFT, but if we can start, and this is not on you, but if we can start showing data that running almost 3 to 6 sessions of just pre-contemplation, contemplation, or just engagement motivation, then I can get through almost a whole coping cap protocol in 3 more sessions, right? So once I actually take the time to properly engage my patients, and as a family, we're all on the same team, or at least in the therapy room, we're all on the same team, and we feel that we're like our goals for treatment are aligned, the actual behavior change, the number of sessions it takes to actually do that behavior change shrinks substantially. And it might feel like, I'm not even sure if I'm answering your question, Amy, other than things you might already know, but it might feel like to people who say, we've got to run the protocol because I only have a limited number of sessions, you might actually find you can reach treatment graduation faster by actually delaying the actual action stage in therapy. And I might argue, right, this concept of therapist as a cog in a wheel, where, I mean, you're probably the same way. I love it when I actually get to graduate my patients. And I'm the one who says, you did it. We've got our goals. You met our goals. I'm so proud of you. We got to fade, and look at you maintaining. Look at you doing this. And like, that feels so good. But the reality is I don't always get to see that and have that with the patients I work with, right? But conceptually, I would rather, even if I have, say, 8 sessions, I would rather do 8 sessions of matching with the person that says, I get you, I get you, I get you. It's possible, it's possible, it's possible. And please don't give up, because damn it, we're behind you, or darn it, rather. I'd rather do 10 sessions of that and and insurance says, okay, enough is enough, and that be the message that these kids are left with, or these parents are left with, rather than 10 sessions of you got to do it time limited, I got to do it time limited, got to do it time limited, because that doesn't send the long-term message to anyone if they're not ready.
Well, and Eddie, I think you make an excellent point, right? That for some of our families, and I think you highlighted this earlier, like I think about it, how many years have they had so many negative experiences, right? And with therapy, and you're providing this corrective, ideally therapeutic experience for them. And maybe what you're doing is preparing them for the next episode of care,
Yeah.
right? So that next time they come into it with a more positive viewpoint. And ideally, I mean, I've had patients come back to me after a year or 2 years, and now they're in a better place, and we've got more time, whatever it is, right? And it works out better. And hopefully, just as a mental health community, we're setting each other up to have better referrals for patients. I mean, how many patients fall back off of a caseload, right? And so it's the long play, right? And I just like, I like the way that you set that up, Eddie, and talked about that. It's the first step, right? These strategies are what set you up to be able to do the kind of evidence-based work that we know is effectively doing the clinical change, but if they're not motivated.
Yeah, and again, even if it's a behind the scenes afterwards, right? If you just set that mousetrap that says positive change is possible, then yeah, hopefully that next round of care, or that next potential family breaking point, or that next potential whatever it is, now they're ready to be like, okay, I'm actually ready and I'm asking for help. And so they're going to enter treatment from a more, I'm ready for planning, ready for action, more in an immediate sense. Yeah, Amy, that's an excellent question. And I hope to those listening that concept makes sense. It's hard to think you're not helping actively in session, but it's a long game. It's a long investment. It's a long hustle kind of an intervention there. And if you put faith in that, do a behavior that's going to minimize resistance to actually maximize eventual change. Yeah,
there's another comment in the chat, just from Glenda. Just reading, Eddie. It says, this is a hopeful presentation. We usually find common ground during the first meeting. A lot of our folks have people telling them what to do. We encourage what they are doing right already and offer suggestions to move forward.
Yeah, that kind of solutions focused oriented approach is almost always more productive than a problem focused oriented approach. Yes, yeah, thank you for that comment. Yeah, I'm glad to hear that. Keep maximizing that.
What I also appreciate is that not everybody on here is a therapist, and these are still things that you can do to help support the therapist without having to be a therapist. Just as he mentioned there, and that comment that Glenda made supports that too. So these are great strategies, I think, for everybody.
Yeah, thank you, Drew. Okay, I'm looking at the time. I want to shift here to talk about functional family therapy and the foundations, or the kind of broad strokes of FFT. So that we can have some more time for some potentially more questions. But okay, I, disclaimer alert, very much identify as a functional family therapist and one who does functional family therapy. Even when I'm doing individual therapy, I utilize a functional family therapy mindset. And for those of you who may not be, as familiar, I want to broad stroke what the stages of FFT are, so we can utilize kind of what FFT brings to the table as a slightly different approach to our basic, more common behavior change techniques. Okay, basically what the FFT providers did was they combined the stages of change research and those models with their typical kind of behavior change treatment models, your CBT, TBT, behavior skills training, trauma focused stuff, so that the tone in therapy was one that embodied more of a self-empowered and relationship-oriented approach to care. Right? Originally, this was developed, with the kind of the chronic juvenile delinquency population. And they are recognizing that, like, when we just drove in with our kind of CBT change-oriented approach, and I'm a CBT therapist, right? They recognize there's like a compliance hierarchical tone to running typical CBT protocols. And as such, it's just not effective. It's less effective, and I'm getting all this resistance. So they purposely tried to shift to this more self-empowered, interpersonally connected based intervention. And in their literature that they've built, they were actually able to get some kind of typical hard to reach populations and tough to reach populations to start actually engaging in that therapeutic process. Okay, in general, there's 3 stages, 4 depending on who you talk to. The first stage is this engagement motivation stage. Some people will separate engagement and motivation into 2 specific stages, but generally speaking, we'll combine them for today. So we've got engagement motivation stage, we've got your behavior change stage, we've got your generalization stage. Just to briefly blow through this, right? The engagement motivation stage, this is loosely involves all the strategies we just talked about, from pre-contemplation and contemplation, right? Anything we can do to bring the person in, feel good about being here, feel engaged about being here, feel hopeful about being here, and feeling like everyone in the room, whether it's just patient therapist, whether it's patient family member, whether it's patient sibling, patient friend, patient mentor, patient community member that I trust, anything we can do to feel like we understand each other and we have common goals, that's what the engagement stage is all about. And only when we've successfully met this kind of goal around, we know what we're doing here, we feel reasonably on the same page, we still don't know what to do about it, but we feel reasonably on the same page, then and only then will the traditional FFT providers shift to behavior change and actually start providing planning and action kind of based suggestions. And loosely, the behavior change stage are all the things you already do, right? You know, whatever your kind of therapeutic orientation of style is, your CBTs, your DBTs, your ACT, your skills trainings, your, you know, motivational interviewing, your whatever it is. It doesn't quite matter. FFT has their own specific things, generally speaking, but generally behavior change is behavior change. And then the third stage is this concept of generalization, right? In our training, we often talk about skills generalization as being an important thing, but FFT really embodies generalization, and in a way starts out treatment with the concept of generalization in mind, even from session 1. I forget who made that comment about already session 1 talking about what the patient's doing well, so we can highlight that and do more of it. According to FFT providers, there's 2 goals of generalization. One is to increase the client's confidence that they can manage their care more independently, as well as further connect those clients to more long-term community-based resources, whether it's actual community resource or family resource or friend resource. So if I'm starting sessions off being like, hey, what are you doing well? What goes well? Like, you know, talk to me about the things you're proud of. We can consistently highlight that, and it sets them up for, oh, I'm more better off than I think. Oh, I'm more capable than I think. Oh, like I can do this. And the more independently competent our kids or our families or our parents feel, regardless if they're still managing the stressors that they came, you know, into session with, if I'm feeling independently competent that I can manage it, perhaps that's the best outcome data that we can often take. Okay. For the purpose, this is not an FFT presentation necessarily. If you guys want me to talk about FFT, I will, maybe in a future presentation. But for the purpose of this presentation, applying the functional family mindset is one that really focuses on that engagement motivation stage before moving forward with the behavior change. Classic FFT people will say, hey, most interventions start and end with behavior change. They say, stop that, right? You got to engage first, even if that's all you do. FFT people will say most interventions fail to incorporate proper treatment generalizations. FFT people say, stop that, right? Before we actually leave, if we have the capacity to, let's let, the kids or the families start running their own therapy sessions within therapy so they can recognize, with the provider becoming further and further back in the room and more quiet, so that the families can have that confidence that they can do this. And FFT people will say most interventions are individually oriented. All right, FFT folks will say, stop that, right? Even if you're doing individual therapy and that's all that's available, stop making it about the individual, that it's their responsibility to do all the change that they need, right? To have all the change that's necessary. If there are parents involved, right, let's rope in that it's their responsibility to kind of model and support you, and they've got a piece in this. If there's not parents involved, like maybe that's a different family member. Maybe that's just a community member or a community group, even if it's just conceptual, right? But if we stop putting the burden of change, especially on the kids we treat, and they're responsible for some things, but once we say the world of change is on your shoulders, the traditional FFT provider will say that's not only too much pressure to give to a kid, but that's, well, quite frankly, just inaccurate. So the more relationship oriented our care can be, even if it's, hey, I just want you to have an open relationship with me as your provider or providers in general, the more relationship oriented our care can be, the more engagement and motivation we can do in session, the better treatment will be. And the more we try to purposely set up for that generalization and what will treatment graduation look like, the more effective treatment will be. Okay. But specifically, we're here to talk about engagement motivation. In keeping the FFT mindset, a couple of specific things I would encourage us all to just do our best with. One, I'm a broken record with this one, but engagement motivation, supporting contemplation, pre-contemplation, that's critical to accessing behavior change. There is no behavior change unless we go through engagement motivation first, right? Even if that's all you do. Shifting from a compliance-based intervention to a self-empowered intervention, right? Especially when you're working with kids in the system, especially when you're working with burnt out parents. Everyone gets sick and tired of just being told what to do. And as a new therapist in that person's life, it's really easy. I've done it myself often, and I'm sure I'll do it in the past. It's really easy to get stuck in this, like, oh, I've got skills. I'm hopeful. I'm endless, I'm an endless bucket of positivity and hope. Like, here we go. And if our hope gets us carried away, it's going to sound like we're just telling our patients what to do rather than matching with them. Traditionally, you can assess for engagement motivation in session. One simple way to do this in the FFT literature is to, everyone gets like this imaginary number in your head. Let's call it 1 through 5, right? So if I go in session, I'm like, all right, I'm a 4. I'm almost always a 4 or 5, depending on my mood for the day. The kid might be at a 3, parent might be at a 5 or 4.5. Right? Meaning they're super engaged and they're ready for change, but the kid's at a 3. Right? So when I step in session, I read the room and I put my numbers on everyone. I say, okay, I got to focus on engaging this kid. Mom's already ready to go. Dad's already ready to go, or grandpa's already ready to go, but kid's not. So that's who I'm going to focus on my engagement motivation strategies, which I'll talk about in a second. Right? That's the kid I'm going to validate. That's the kid I'm going to say, tell me your story. That's the kid I'm just going to do my best to just reframe and make him feel like, he's a good human being and the goals he has for his life are valid and worthwhile to pay attention to. Or sometimes it's the mom or dad or the parent who's a 2 and the kid's a 4, right? That's the person I want to focus on. Right? So everyone gets a number, and I'm just going to try to get everyone to the same number before I move forward. If people are different numbers, we're going to increase treatment resistance because they're not ready or they're not doing their part. Okay. As far as direct strategies go, validation is your best friend. Validate all over the place. But you already know this. What's some language that FFT would use in some of their engagement motivation strategies? They love to talk about reframing to noble intentions. So don't just validate, oh, that makes sense to me. Like, reframe that in a way where you're highlighting the noble intention behind that behavior. Right? So a parent who just shuts their kid down and doesn't let their kid go outside or go to parties or I don't know, leave the house, or, you know, you have to get all A's on your homework, or I don't know, whatever it is. Like, that's rough behavior to hear as a kid, but you can highlight that this, I don't know, this anger or this rigidity probably comes from parent anxiety. Let's talk about anxiety. It's more accessible and more empathy oriented, right? Or a kid who's just shut down and keeps his hood over his head and just doesn't talk anymore, right? That's a difficult behavior. But if we can recognize that that shutdownness, that closed offness is like, hey man, I get it. You need to feel protected, and this sucks, right? You feel attacked, so you are protecting yourself. Talk to me about why you need to feel protected here. That makes his very closed off, hooded behavior accessible and able to discuss and talk about in a therapeutic issue. And if you're having those conversations in the presence of, say, a parent who's angry or thinks their kid is difficult, then all of a sudden you're talking about these really difficult behaviors in much more humanistic terms. Okay. Reframe the noble tension. One of my favorite languages here is this concept of fearless empathy. In tying our very first slide up until here, right? This is that concept that as a therapist, I'm going to do my best to enter the room with just this mindset that I am fearlessly going to understand that what you're going through and your coping strategies and what you're trying to do with deal with what you've experienced, that makes sense to me. And I'm not putting you down for that. But I'm just fearlessly empathetic. Oh, more and more resistance, more and more difficulty, more and more, falling apart in the room. Like, hey, let me read that as you really need some protection. You really need some support. You've really been through some stuff. Let me take a step back and, contemplate and engage and validate. You're not ready for me to tell you. You're not ready to work on this. You just need to know that someone understands what you've been through and what you're going through, regardless of how intense that is. But for you, it's clearly intense. So this concept of fearless empathy is huge if you could bring that into the room with you. Anything you do to identify shared family values. The second you can say, oh, sounds like you guys want the same thing, and get them kind of nodding along to that, that's when you know we're closer on the same team, closer on the same page, and closer to working together. The more we can work together, the less resistance we're going to have. Anything you instill hope for the future. Tell me what you're already doing well. Oh my gosh, this is possible, right? Stay in the room, right? Pay attention to what's happening. Like if someone says something and someone flashes a smile, be all over that smile. Like, hey, Ma, you're smiling about that. Oh, yeah. Did I just detect a laugh there? See, you guys can work this out. You guys can work together. And it turns out all hope isn't lost, is it? Right? Your ability to stay in the room and pick up on that body language allows you to identify, we can do this. Or maybe they just had a huge argument and now all of a sudden they're sort of talking more calmly now, right? Stay in the room and don't let that go. Be like, hey, you see what that just happened there? We just blew up at each other and now look at you guys. You've got this. We can come back together. A blow up isn't the end of the argument, but you can take a break and we can have a better conversation. This tends to be more helpful for families and more helpful for parents, but highlight skills deficits, not performance deficits. Parents very stereotypically tend to, say things like, he's lazy, or they're lazy, or, they're something like that, kind of a character assassination when describing, difficult behaviors. Anything we could do to talk about behaviorally specific what's going on, or the fact that this is a skill that they haven't learned yet, rather than something they're doing on purpose. Anytime we can make it about the skill and rather about the person making a purposeful choice, even if it really seems like a purposeful choice, that can really alleviate some of the anger and frustration around the conversation, and get more into, oh, we're here to learn a skill that we haven't learned, because instead we've learned a different way. I guess finally here we have pairing potentially critical statements with validation statements, right? We all know the sandwich method, but I'm putting it in there anyways. When I'm teaching this concept, I specifically try to identify pairing potentially critical statements, especially when parents are talking about kids, or we're talking to kids, or we're talking about parents. It's really easy for a person, if they're entering the therapeutic concept, if they already have the mindset that I'm going to get yelled at, or all my faults are going to be identified, or I'm doing something wrong and that's why I'm here in the first place. If we could make sure, oh, I'm about to say something that could potentially be perceived as a critical statement, I'm going to lead and follow up that statement with validation to make sure that the message I'm trying to actually send gets through. In many cases, this is important when you're talking to parents, especially, because as soon as you start roping up maybe a low engaged parent, they say, hey, you need to be doing more, or you need to be doing differently. Often, parents, treatment resistance comes from burnout themselves, right? I've already done it all. I've already tried it all. And you can't tell me I can't be doing more, because at this point, I can't be doing more, right? And so anytime you ask a parent, like, hey, parent, I need you to be doing more, in whatever language you're using, you better back that up with some validation that says, I understand your burnout here, right? I understand that it doesn't feel like you can be doing more, because you've already done it all. And, here's where I need you to be if we're going to move forward with this. As far as direct FFT strategies go, of all of those, that concept around fearless empathy, and I'm going to understand you, I'm going to understand you, I'm going to understand you. If there's anything that I do in this world, that I will understand you. And I'll do my best to understand why the reason why you're in this position is not totally your fault. And that there's something we can do about it. And there exists people out there that actually would love to help. Of all these strategies, or all those, kind of direct tips on there, that would be the most important concept for this one. Okay. And that's the FFT mindset. Use it for your individual clients, use it for your family clients, but use it. Yeah, use it. That's all I have for you guys. I think we have a good handful of minutes. If there are other questions, I'd love to answer them. Any particular application questions, I'd love to answer those. I think, Caleb, you'll be sending out the slides to everyone, and my contact info is on that. So if there are any follow-up questions or any requests for clarification, I'm very happy to respond to that. Yeah, office-wise, I mean, we're in the process of setting up even provider trainings in family therapy. So if learning more about family therapy or functional family therapy is something you want, let me know. If you know any good postdocs or providers, technically we're hiring too. Maybe, Caleb, am I allowed to make that plug? I'm making that plug. We're hiring.
You're fine.
Okay.
You're going to have to get them to move out to Colorado, but it's fine.
It's true. Yeah. It's true. So it's a beautiful place to be. It's raining today, but I think we're getting 20 inches of snow in the mountains, so a good spring ski is in order if that's something anyone's into. All the free time that we have as therapists, right?
Good self-care though.
Yes, it is. Yeah, any final questions or reactions or comments?
Oh, Amy, I see you're trying to talk, but I think we can't hear you.
Oh.
I see Amy, yeah. I still don't have your audio. If you want to type it in the chat, sorry. If you want to type it in the chat, we'll wait for you.
Thanks, Amy, for your involvement
Yeah.
in interaction.
Yeah.
Yeah, and last slide too, technically, if you are interested in more of, if there's one resource you look into, it would be, you know, consistent with almost all of the messaging in today, would be stuff from probably Alexander, in terms of their functional family therapy for adolescent behavior problems. It's in Sexton and Alexander, the clinical training manual, I think is like a harder and clunkier read. But that first resource, FFT for adolescent behavior problems, I think it's applicable, and it's a really great read, whether you're doing traditional family systems work or not. It's a really great resource to have to kind of develop some of that stages of change integration into the work you do.
Eddie, I just want to take the time to say thank you so much for the presentation today. I really appreciate it. I think this was a topic that a lot of people have requested, and so just being able to talk about how to work with our families that, you know, we struggle with as clinicians and find difficult, even though it's not a quality of them, but, you know, our own perceptions of that. It is so helpful. So thank you so much. I know this is appreciated, and I just want to remind everybody, we'll you know, fill out the survey. It's in the chat. The slides are in the chat, as well as Dr. Mockus's contact information. So if anybody has any lingering questions, please feel free to reach out to him directly. We'll be meeting next month. We'll have Dr. Berkeley presenting to us on using collaborative problem-solving approach to work with families. And then also preview a couple weeks after that, we'll have the Grow With Me clinic from Children's Hospital coming to present to us about neonatal abstinence syndrome, how to support families dealing with that. So thank you all again for joining us. Appreciate it. Hope you all have a good weekend.